Hi, I'm Michael Mauro from Memorial Sloan Kettering Cancer Center in New York. I apologize for not being able to deliver this live with Dr. Bhatia, but this is the International CML Foundation updates in CML, the clinical portion. I wanted to thank the iCMLf for inviting me to do this again. I apologize profusely for not being able to present in person, but I thought this recording might be helpful, and I hope it's helpful to you. A lot of data, so let me share my screen. We can get started. First off, a nod to the patient advocacy groups and societies listed on the bottom, including the iCMLf for our Kilimanjaro climb and the New York City Marathon recently, and other groups that have similar ideas to help patients with CML. And most exciting data, I think, to start off with, came from the ASCIMINIB trials. We have data from the ASCEND and the ASC4More trial. Tim Hughes presented on behalf of David Young, who unfortunately couldn't make it, and Jorge Cortez presented on behalf of the ASC4More investigators. So the ASCEND trial is a trial of newly diagnosed chronic phase CML treated with asciminib. Here are the entry criteria. And standard dose of asciminib. Assume patients are meeting optimal milestones. Option to increase the dose for patients who have suboptimal response, and the possibility of adding a combination approach with asciminib plus an ATP competitive inhibitor for patients with missed milestones. Our first look at asciminib in the front line looks very promising, and this is compared to the Title II trial, which was higher dose of imatinib optimized, i.e. increased or switched to nilotinib under the setting of missed milestones in a very similar fashion to this trial. You can see early molecular responses exceeding 90%, and then onto MR2, MMR, and MR4. Very nice at 3-month capture of these responses. And I think this looks perhaps similar or is besting the data from the EPIC trial, where Ponatinib was used in the frontline as well. Unfortunately, that trial was halted for adverse events. So asciminib may be our way to break the glass ceiling with higher doses in newly diagnosed chronic phase CML. Some patients did discontinue, and the reasons are listed here, including some biochemical changes, issues related to poor response and marrow failure, 1 lymphoid blast crisis, and 1 myristoyl pocket mutation. The adverse events of particular interest are noted here. Grade 3/4 myelosuppression, fairly modest, and again, not surprising early in treatment. Lipase elevations noted, perhaps as expected. And the other adverse events of higher grades or frequency noted here, very modest. And I think a particular note is that arterial vascular occlusive events so far are coming in at 0 for this trial. I think we need to follow longer. But with our first look at newly diagnosed patients being exposed to asciminib, this is extremely encouraging, and I look forward to more on this report. The ASC4More trial was an optimization trial of asciminib, where patients who had a year or more of Imatinib with response somewhere between a 2 and a 4 log reduction. We're looking to optimize the response through a multi-group randomization, either staying on Imatinib to just treat longer, switching to nilotinib, or adding asciminib at 40 or 60 milligrams daily to the standing Imatinib dose. And the primary endpoint was MR 4.5, the sort of finish line, if you will, of deep response at 48 weeks. There was a monotherapy arm added later on in the trial, given the standard dose once daily. So the primary endpoint is shown here. We can see that when switching to the combination of asciminib 40 or 60 rather with Imatinib, that the highest yield was gained. No patients who continued Imatinib were able to move to MR 4.5 at week 48, and more modest numbers moved forward from nilotinib. And this trend had begun at the week 24 interim analysis. The overall adverse events are shown here, and while patients who switched to asciminib plus Imatinib did have more adverse events overall, they were not exceeding that of those who switched, patients who switched to nilotinib. So getting more specifics regarding adverse events here, we see some of the things we might expect to see, such as rash and electrolyte or liver enzyme perturbations with nilotinib. Lipase increases were seen across the board with all arms, and some more GI toxicity and myalgias pruritus with the combination groups. These may be due to one or both of the TKIs or the combination. I think a modest toxicity profile, and it was not dose dependent of note for the combo arms. So I think that's very encouraging, and we need to think of that combination strategy more. Moving on past asciminib, we'll now look at Olverembatinib. which is a novel third-generation TKI developed so far primarily in China. There are presentations by Dr. Zhai from Ascentage on behalf of Dr. Jiang from Peking, and on behalf of the collaborators, the physicians on the trial, and from Elias Jabbour, where we have some data from outside of China on this agent. So Olverembatinib, or formerly known as HQP1351, has been shown in previous reports to have very good activity in chronic phase CML with the T215I mutation, without, and as well as accelerated phase CML. Sorry, it's a bit small, but I think you can glean the high rates of response and cumulative incidence of response in both chronic and accelerated phase CML, as well as the progression-free survival. Long-term follow-up, now median of 50 months, was presented at the meeting with durable responses, patients treated beyond 30 milligrams, and adverse events diminishing over time, particularly myelosuppression and modest rates of arterial-occlusive or venous thrombotic events. You can see in the table, hyperpigmentation is very common. There were some new side effects seen at higher grades, such as proteinuria, which might require a bit more investigation, and fever, but I think overall myelosuppression as well. There were high rates of thrombocytopenia with Olverembatinib, which again were specifically detailed in the report to be diminishing over time. But as you can see, roughly 3/4 of patients have thrombocytopenia of any grade, and about half grade 3/4 in this later line treatment population. There was a second report from the same group focusing on the T215I population, where again the survival looks excellent, and responses are seen in both chronic and accelerated phase. It's important to note that when we look at Olverembatinib data outside of the in these Chinese trials, these are patients who did not have Ponatinib exposure nor ASCIMINIB, because those agents weren't available. But the overall report and the specific report are very encouraging. We do have a report from Elias Jabbour looking at a combination of advanced Ph-positive leukemias and chronic phase CML using different doses of Olverembatinib, some being bridged to transplant, and most often receiving later lines of therapy. And I think if we focus on chronic phase CML, we see that about half of these patients had prior Ponatinib, and roughly 3/4 or slightly less were resistant. So this is perhaps a bit more what we've been asking for. How does it perform under these settings? And again, about 1/3 with the T215I mutation. Here's the overall data for chronic phase. And again, for the target dose of 40 milligrams and lower doses, you can see high rates of cytogenetic and molecular response. And particularly for the Ponatinib failure, remember, half of the patients were Ponatinib failures in chronic phase, and 70% of them were resistant. And you can see that population is doing quite well under Olverembatinib. So this is very encouraging. And the T215I mutation patients, as in other subsets, have fared well despite this difficult mutation. The adverse events are shown here: myelosuppression, grade 3/4, and the non-hematologic toxicity. Now, again, in contrast to the data in China, we don't see some of the same adverse events. And I think overall, the sense was that the adverse events were a little lower in this trial. But I think we need to see larger numbers of patients treated in a broader setting to understand all of the adverse events. But this drug was very promising. Lastly, the arterial occlusive events that were deemed related to Olverembatinib were 2 isolated cases of angina and cardiac failure in the different doses shown here. So again, a low perceived risk of arterial occlusive events. Moving on to Vodobatinib, another third-generation TKI presented by Jorge Cortez. We have an update of the phase 1 trial, which is a long effort, where the doses have been pushed up to some of the higher ranges, which are therapeutically perhaps ideal, and where tolerability is still very good. We've had expansion, and we have follow-up now over longer periods of time. This is the subgroups where you have patients either with 2 or more lines of therapy, 3 or more lines of therapy, prior Ponatinib, and even some patients now with prior ASCIMINIB. And this is the overall number. Here's the response data, and these are patients achieving major cytogenetic response on study. I think very encouraging. Second and third line patients somewhere in the 40 to 60% range, overall rates around roughly 50%, and even after Ponatinib, again, not particularly a T215I mutation bearing population, given the limitations of this drug in the vitro laboratory studies, but I think still very encouraging. And then MR3 rates, or MMR rates shown here, again, roughly 30 to 50%, including the Ponatinib exposed patients. I think it's early days for the ASCIMINIB patients, but we are seeing activity. If we look at landmark analysis, we can see the shifting of patients with no response at the start of of treatment was, for example, on Ponatinib to the majority to the minority, with about half patients with complete cytogenetic remission. Similar for third-line TKI, and 3 TKI exposed and 2 TKI exposed groups, and their overall response rates are shown here. The molecular responses, again, baseline, we had very little. You can see that at 24 months, we have somewhere between a quarter and a half of patients into an MMR, which I think is still viewed as a safe harbor, and I think perhaps a goal when you're dealing even in salvage for these difficult patients. This is very encouraging as well for Vodobatinib. Treatment adverse events of high grade are shown here, myelosuppression. And again, probably a class effect. We see it across all the TKIs. We see pancreas enzyme elevation. There were some more serious complications, some permanent discontinuations, some related to disease progression with intracranial hemorrhage, including COVID as well. This was run during the year of COVID. Not a strong pattern or signal here. And I think in a difficult population, the tolerability of Olverembatinib looks quite good, and response is very encouraging. Again, perhaps a bit more limited with T315I mutation, or not the drug to focus on for that population, but otherwise at these appropriately high and safe doses, I think Vodobatinib is performing very well. Cardiovascular adverse events have been modest as well. If we focus on the grade 3, we see, again, this is a broad list of potential vascular-related complications. The majority were deemed to be unrelated to Vodobatinib and grade 2 or less, so no strong signal here. Moving on to other presentations, we had a bit more on Dasatinib 50 milligram follow-up from the MD Anderson group, a nice study on PEG-INF for treatment-free remission, and an update on the OPTIC trial from Jorge Cortez. And Dr. Boucher presented the PEG-INF data, and Dr. Genericos presented the Dasatinib data. So looking at 50 milligram Dasatinib, we now have long-term follow-up from the MD Anderson trial, which again, it was a single center phase 2 trial, which has been analyzed quite thoroughly, though. In this study, the age is on the younger side, and there is probably a higher fraction of low-risk patients. That was the input of the trial, and so the readout has to be taken in context. But historically, 100 milligram Dasatinib, which is shown in red here for MMR in pink and MR 4.5 in dark red, compared to the Dasatinib 50 at 1, 2, and 5 years, we can see how, interestingly, the Dasatinib 50 seems better than the historical 100 milligram dose. This is not a randomized comparison. This is just historical data placed side by side, and then of course compared to Imatinib. So Dasatinib 50 at 5 years, has exceedingly high rates of molecular response, including very high rates of MR 4.5. So I think this does pique our attention and requires thought. The survival probability, if we look for overall and event-free survival, are very high, and this is treatment and failure-free survival. So I think the long-term follow-up, again, 5 years, looking very good. And the adverse event profile here, grade 3-4 events have been quite minimal, and in specifically looking at pleural effusions, which was perhaps a limiting adverse event with 140, brought us down to 100, can be seen over multiple years of exposure is quite low, particularly grade 3-4. So I think these are some of the points to highlight related to this. And as well, some patients were able to dose decrease down to very minimal doses. Some did increase or change. And as was questioned during the session, they have lower rates of TFR entry, but this is just the point where patients would start to engage for TFR discussion and initiation. So we'll have to see with longer follow-up. So very encouraging data for 50 milligram Dasatinib as potentially a dose to consider. Although randomized data would be the proper way to vet that. The Endure trial was a trial using PEG-INF as a means to perhaps improve the rates of treatment-free remission down in Germany, and nicely presented. And these are the two arms, as you can see, either an observation surveillance arm for patients who cease TKI therapy versus patients who use PEG-related interferon for a period of time to see if this would improve outcomes. And this was a somewhat negative trial that you see that during the treatment versus observation period, there was slight differences, but really no long-term or no consistent improvement in molecular relapse-free survival between the two groups. If we looked at subgroups for including patients who had 6 or more years of prior TKI therapy. There looked to be a difference early on, but that did sort of, the gap narrowed as the interferon effect was perhaps faded. If you looked at specific subgroups, such as patients who had 6 or more years of prior TKI, and this was their first stop attempt, this trial did include patients who had more than one attempt at stopping therapy. Now we have a more consistent impact from the addition of ROPEG interferon in this population. The added tolerability issues with ROPEG interferon were, I think, modest. There were some similar rates of bone pain or general discomfort, higher rates of GI toxicity and fatigue, and as well a single episode of neurologic toxicity, and the other side effects are listed here. So I think, while potentially a source of tolerability issue, the addition of ROPEG interferon was pretty well tolerated. I think it's more interesting that it may come out of single cell sequencing data, which was the schema was described at the meeting, where we might be able to identify specific subpopulations of cells related to perhaps the immune effect of ROPEG interferon or T cell specific immunity. So stay tuned for more data on this to help us sort out this question. Moving on to the OPTIC trial, this has been reported previously, but this was the optimization of Ponatinib at different doses with reduction to 15 milligrams on achieving response. This was longer term follow-up. And again, this is patients with 2 or more TKIs and potentially T215I mutation positive patients as well. So the advantage of 45 milligrams continues to be evident with longer follow-up. And this remains in our minds probably the ideal dose, starting at 45 milligrams with reduction to 15 milligrams upon response. The progression-free and overall survival, this looks particularly to be overlapping, although there may be an emerging change here in the PFS with the 45 milligram starting dose at 3 years plus follow-up. If we look by mutation status, we've always touted the vast improvement for patients with the T215I, although even those without mutation or other mutations, there's an advantage for the 45 milligram start, although it's more modest. If we looked at the notion that patients do restart the treatment and may need to re-escalate, I think what we see is that for those who re-escalated after loss of response, where the numbers are here, the majority of these patients regain their response, and it's rather quick. So I think this is encouraging that only small numbers need to re-escalate, and when they do, they regain response with this dose reduction schema. And the grade 3 to 5 adverse events are shown here. And I think the message is that there isn't seemingly a difference between the 3 arms, perhaps in the more prominent myelosuppression, such as thrombocytopenia or other side effects, including hypertension and other AEs seen here. The 45 to 15 milligram dosing doesn't seem to be significantly different. Arterial occlusive events are summarized here, and they were more numerical. The exposure incidence rate is similar, and the grade 3-4 events are quite similar across the groups. So I think in this more current analysis of Ponatinib, we see lower rates of arterial occlusive events, again, numerically somewhat higher, but not specifically higher grade or fatal, and seem to be manageable to get these difficult patients into response. There were some nice presentations on non-ABL myeloid mutations from Dr. Shanmugatnam and Dr. Kim from the Adelaide group and the Toronto group. The question here is looking at beyond BC-ABL, and in the Adelaide group, looking at what was aberrations in the region of ABL or BC-ABL and other fusion partners and other myeloid mutations, sort of as distinct groups. So either cancer gene variants or pH-associated rearrangements. You can see amongst Imatinib-treated and second-generation TKI-treated patients, these were not infrequent. And there were some patients with both events. So I think this is quite intriguing. ASX01 was the most frequently mutated gene, and it was similar proportionally in the Imatinib and second-generation TKI-treated groups. And also TET2, RUNX1, and DNMT3A were also recurrently mutated and climbed to the top of the list. So did this have an impact on response? I would say the signal is coming through a bit. For second-generation TKIs, not as different at 12-month or long-term analysis. But for the Imatinib-treated cohort, the p-value is significant, and those with the additional genetic abnormalities seem to have a lower rate of MMR. Also lower rates of MR4, again, noticeable for Imatinib, whereas the second generation TKI, there was a difference as well here. So this deeper response seems to be elusive in both groups. And specifically the ASX01 group tended to have the most impact on failure-free survival and the acquisition of kinase domain mutation. So this may be the link between the non-BCR-ABL and BCR-ABL kinase domain mutation story in resistant CML. Second study by the Toronto group looked similarly at myeloid mutations, categorizing them into pathways. And again, similar types of mutations were seen. They grouped them into these abnormal activated signaling or myeloid patterns, and the impact here was that at initial diagnosis, any mutation unfortunately reduced the likelihood of response. You can see for Imatinib, particularly, not for second generation TKIs, and that was the take-home message here, that second generation TKIs might abrogate this effect of a myeloid mutation on rates of MR2, MMR, MR4, failure-free survival, and progression. So I think important data to continue to consider. And if we look at the specific grouping of this activated signaling pathway and myeloid transcription factors, again, the impact was higher for Imatinib and was more neutral for second generation TKIs. It seemed to reverse the risk, as the author said. So I think you can see the difference on for all patients in Imatinib and 2G TKI treated patients for failure-free survival, where for Imatinib there's quite a difference, whereas for 2G TKIs it's been diminished, and progression in advanced phase, again, similar for the two mutation present or absent, whereas with Imatinib noticeably higher, and again, overall the Imatinib group did push this up based on the data here. So I think there are differences in these studies, and I think the genesis of data regarding non-BCR-ABL mutations in chronic phase CML that is outside of BCR-ABL really are showing prognostic significance, both at diagnosis and during treatment. A few last reports on some of the more distinct topics of TFR, race and ethnicity in CML, and the elusive or fading question of accelerated phase CML, how to treat, and the blast crisis registry. So the TFR-PRO study looked at patients who decided to or did not decide to stop from a collaboration across Europe and in Canada. This was a large study, 906 patients, looking at the attempts at treatment discontinuation and how the outcome looked, including transformation. I think the number of deaths in this large cohort was small, all unrelated to CML. As predicted, there were patients who lost major molecular response in both groups, patients who had treatment discontinuation with a time-adjusted rate of 11 per 100, and those who did not attempt, a time-adjusted rate of 2 per 100. The finding of importance that was highlighted was there was a patient who progressed, who had a very good early treatment response trajectory and had treatment discontinuation with loss of MMR, MR3, and then unfortunately had poor compliance to treatment. That's what the figure shows, where the patient never really regained much beyond MMR, and then unfortunately had a blastic crisis, but was salvaged with chemotherapy and allogeneic transplant. So I think the take-home messages were that progression is rare, but it can develop in patients who discontinue. Not proven. I don't think that's the message, but the patients who plan treatment discontinuation should know about these very rare possibilities of disease progression. And I think more study of this question is needed. It's a very nice and important study by a group at the Huntsman Cancer Institute regarding race and ethnicity in CML and its impact on treatment outcomes. And just to give you a few images from their presentation, based on different races, white, black, Asian, or other, we saw differences in cumulative survival for all patients, but particularly if we looked at, for example, patients less than 65 years old that African patients or Black patients did more poorly than white or Asian or other. So I think this is an important message that there may be some connection and need to look at subpopulations and their access and their treatment. Interestingly, when ethnicity was looked at, Hispanic versus non-Hispanic, which was the main arbiter, and this was from a SEER data analysis, Hispanic patients did better, and as well, it was in all patients, perhaps not the older, the younger population versus the older population, but this was a curious finding, and I think in the discussion it was thought that maybe better family support or social structure support might have something to do with it. In multivariate Cox regression analysis, so factors associated with worse survival beyond what we've already seen included patients of increased age, comorbidity, uninsured status, residing in a lower income area, and residing in an area with lesser penetration of higher education. Factors associated with an improved survival included Asian race, other race, compared to white and Black, and Hispanic ethnicity of note, and female gender. So I think these are also important questions that need to be looked at as we improve the whole picture for CML across on a global setting. And this was, again, this year data here in the US, but very important. So this is a data from a presentation presented by Dr. Gale, which was on behalf of Chinese collaborators looking at accelerated phase CML and the difference between second generation TKI treatment and Imatinib. You can see the advantages of second generation TKIs coming through regarding MMR and MR 4.5 and accelerated phase CML, and this is in general. Whereas the long-term treatment-free survival and overall survival, as well as failure-free survival, weren't terribly different. If you broke down accelerated phase by its components and looked at those qualified to be accelerated phase based on increased blast, 15 to 29%, again, you can see that the differences are more limited. And again, there isn't necessarily an advantage for second generation TKIs. If you look at patients categorized by basophilia, which is a different way of looking at accelerated phase CML, you can see the advantages of second generation TKI, again, similar to the overall data on response and failure-free survival, but not perhaps on overall outcome. And if you look at patients with thrombocytopenia, it's interesting, Imatinib actually seems to be a better choice, and that's perhaps due to a different adverse event profile. So I don't know if we had a clear way to sort out the difference in response between second generation TKIs and Imatinib and accelerated phase CML. But it's important to note that the WHO is now removing accelerated phase CML, and we're going to need to consider patients with CML as chronic phase or advanced phase and look more at the biology and understand the differences. So I think this was an important report to help us start to dissect this question. Lastly, there was a registry from the European Leukemia Network, which I just wanted to highlight, that is now trying to gather data on how we do treat blast phase, which is, of course, still an unmet need in chronic phase CML. And as they're starting to gather patients, they're being able to look at the different type of blast phase presentation, the genetic changes, the karyotypic patterns, fusion types, and the high-risk features that may be seen. They can look at the types of BC-ABL mutations identified. That these data are more limited. You can see not all patients are having sequencing, for example, in non-BC-ABL regions for mutations, but the data I think here could be very important. And if we can look at differences between evolved versus de novo blast phase with perhaps high rates of mutations, higher rates of additional clonal abnormalities, particularly high risk in patients who have evolved chronic phase versus de novo. So I think some important observations can be had here. And the treatment characteristics, of course, where the types of TKIs used and multimodality therapy, including transplant, as well as chemotherapy plus TKI. About half of these patients received a transplant. So the take-home messages were that younger patients were receiving Dasatinib combinations and transplant. Prior chronic phase CML, often Ponatinib, not surprising given the likelihood of mutations or prior resistance to other TKIs. Shorter duration chronic phase CML receiving Dasatinib and de novo Imatinib. Lymphoid blast crisis generally treated with Dasatinib and chemotherapy. And again, Imatinib still serving patients who don't have known mutations. We have data on response and survival. And again, this is an unmet need. We need to improve our outcomes in blast face CML. So I'd like to encourage people to reach out to the lead for the ELN Blast Crisis Registry to help better characterize this and help us better treat this group. So to summarize, new agents continue to evolve, very promising. ASCIMINIB, including the frontline, Olverembatinib, Vodobatinib, and others on the way. There are other allosteric inhibitors under clinical development, other third-generation drugs we need to hear more data on, and others coming into development. So the field's getting richer and richer. We saw long-term data on Dasatinib and Ponatinib, perhaps optimizing the dose in both cases. The important impact of non-ABL mutations in chronic phase CML and differences between first and second generation TKIs, continued endeavors in TFR, some thoughts on accelerated phase CML, on race, ethnicity, and disparity. We even had a nice presentation on pregnancy from Elizabeth Dabruzier on behalf of collaborators registering our experience there, and blast face CML and unmet needs. So I want to thank you for your attention and the kind invitation from the iCMLf to allow me to present. Thank you very much.